She had a positive rectal biopsy. She had no diversion in the preoperative assessment of our patients. So this is the contrast enema. As we can see, it's not, I mean, I personally, and when we looked it up, it didn't look suspicious of, really suspicious of total colonic aganglionosis. Just proceeded open because it's a long segment. So we just started with a French tail incision. Started with taking the biopsy. I took a rectal, sigmoid, and splenic fracture biopsies, sent them off to pathology. And because I was quite sure that this is going to be a Hirschsprung, I started with the pelvic dissection, the Swenson technique, and the biopsy came back as aganglionic segments. Still there was no level seen. So we did proceed. We just started to move along the colon, and it was at this moment when we saw the previous images. It was this contrast just appeared intraoperatively and just said, oh God, this is a typical question mark appearance of the total colonic aganglionosis. So we just proceeded. It's a total aganglionic segment. We did the resection. So basically, we did the biopsies. We kept moving on until we were so worried that it might be a quite long segment, even extending into the ileum. But luckily, as you can see in the intraoperative picture here, that it's total colonic and about 5 centimeter proximal to the ileocecal junction was still aganglionic, and there was an evident dilated segment with a funnel, and it was later on, it was just, we finally got our ganglionic sample, and we just came down with the ileum and we did an ileoanal anastomosis and a covering ileostomy. So the question is, after doing this kind of operation, is what dawned on me at that time and on my colleagues. So if we have waited until figuring out that this is quite a long segment, some people told me that it would have been better to do a Duhamel technique because of the continence. We have concerns about incontinence. Sometimes I do reflect on patients with ulcerative colitis who have to remove their entire colon, but the surgeons, the colorectal surgeons, have to fashion a pouch, an ileal pouch, to help them with their continence. So probably the Duhamel procedure is just, of course there is a remarkable difference, but maybe this is in the Duhamel we can create this kind of pouch. When I read in the literature, it said that Swenson technique is recommended for total colonic aganglionosis, given that we do a protective ileostomy, as it allows for colonization of the distal end of the ileum. Well, this term sounds interesting, but maybe Professor Dulator can elaborate more on that, tell us more about this. The other thing, from our experience, one of my colleagues told me that he did operate on such a patient, but a much younger patient, and without covering ileostomy, the patient suffered a lot of excoriation. So I am worried about the continence issues when we close this ileostomy. When do we close the ileostomy? How long does it take to do to allow the distal part to colonize, as it's stated? And what are your techniques to avoid the ileostomy prolapse? I would like to thank my professors, my direct supervisors, Professor Dr. Haitham Ismat, Dr. Gamal Tegi, and Dr. Mohammed Barbari. And thank you very much.
Thank you very much. I have a few comments. Number one, if I had a child that came to me 1.5 years of age with suspicious for total colonic aganglionosis, I would be suspicious that maybe this is not the correct diagnosis. So if I had a healthy child, now if I see a malnourished child that is not growing, then I would be more prone to believe in this diagnosis. Now, the other comment that I would like to make is that we surgeons are very dependent on our pathologists. So if you don't have a pathologist, the best thing to do in a case where you suspect a long segment, do an ileostomy and map the entire colon and wait patiently until you are 100% sure. That's not the case that happened here, but the worst case scenario would be to resect a colon and then find out that the patient indeed had ganglion cells. That would be terrible. That's not what happened here, but just if you don't have a good pathologist, map your colon first, resect only after you know for sure the diagnosis. Now, regarding the technique in patients with total colonic aganglionosis, we prefer ileoanal anastomosis. We do Swenson ileoanal. The only cases in which sometimes this may be a little challenging is when you have aganglionosis up to the ileum. Because if you have long segment of ileum with aganglionosis, if you do the ileoanal and then you want to open a more proximal ileostomy, sometimes you end up opening a very proximal ileostomy that will be hard for the patient to keep it himself or herself hydrated with fluid balance and electrolytes. So that's the only disadvantage. But in most of the cases, you can do an ileoanal and open a more proximal ileostomy. The time that we recommend to close the ileostomy is only when the patient is toilet trained for urine and the patient accepts rectal irrigation. So we give the mom a catheter and we tell her to start practicing, because once you close the ileostomy, the patient will be prone to enterocolitis. I know enterocolitis is not the perfect name because the patient doesn't have a colon anymore, but that's the way we call this disease. So our criteria is that the patient has to be toilet trained for urine, because once you close the ileostomy, the patient will have several bowel movements. But if you did the technique correct, if you preserve the anal canal, if you didn't stretch the sphincters, the patient will have bowel control and will be able to go to the toilet, and that way avoid diaper rash. If you do it too early, when the patient is not toilet trained for urine, the patient will have several bowel movements, severe diaper rash that is unmanageable. Now, regarding how to avoid prolapse in ileostomies, whenever you open a stoma in a mobile portion of the bowel, so the ileum is, the small bowel is completely mobile, there will be a tendency to prolapse. So what we do is we fix the bowel for approximately 7 centimeters next to where the stoma is to the abdominal wall. That way you avoid prolapse. And I think those...
Thank you, Andrea. I agree everything with Andrea. So she already commented all of the questions. Just when you have this image like you presented in the contrast enema, like a question mark, this one, and you have a biopsy of the rectum with a ganglionosis, and you can see dilated segment with air, which is the ileum, the proximal ileum, you can say, I have a patient with total colonic ganglionosis. One important finding in the biopsies, when you have a patient with a rectal biopsy and the patient has total colonic ganglionosis, is almost a genesis of the enteric nervous system. So the pathologists, they don't found ganglion cells, and they don't find plexus, they don't find hypertrophic of the nerves. I mean, between the in the mesenteric plexus there is nothing, you know. So it's a very common histopathology finding in total colonic. So these findings in the rectal biopsy and this question mark for like an hypoplastic colon with dilated segment behind, which is the small bowel, you have a case of total colonic. And then Andrea already said, ileostomy, wait for urinary control, and then do the pull-through. Congratulations.